there, ladies and gentlemen. My name's Dr. Rehan Haidry, and I'd like to thank the organizers of the AWE for this phenomenal and privileged invitation to speak at this meeting. I apologize I can't be there in person. The title of my talk is Endoluminal Therapy for Metabolic Syndromes using Duodenal Mucosal Ablation. These are my conflicts of interest. So in terms of just setting the scene and giving some context, we know that metabolic syndrome, and in particular insulin resistance, and the amount of people in the world living with type 2 diabetes continues to increase significantly. We know that by 2050, 1.31 billion, so almost an eighth of the population of the world, will have type 2 diabetes. And the staggering statistic about this is not only are we seeing an increase in the trend of diagnosis, but also that a lot of these new diagnoses will occur in the developing world, where healthcare is already limited, and the health economics are such that new and innovative treatments are lacking. Now, I'm an endoscopist and a gastroenterologist, so I'm not going to wax lyrical to you about the underlying pathophysiology of metabolic syndromes and insulin resistance and type 2 diabetes, but we know that it's multifactorial, it's a multi-organ disease. But where we can focus our attentions is the gastrointestinal tract, and in particular in the foregut, where we know that there's increased glucose absorption and then diminished incretin response that leads to the changes we see with insulin resistance. And we know that the small bowel is integral in glucose homeostasis. And we know that the proximal foregut and the proximal duodenum is where nutrients initiate this gut peptide release from the enteroendocrine cells. And these will regulate not just appetite, but also glycemic control and fat deposition. So we know that when we look at patients with type 2 diabetes and when we look at patients with insulin resistance, that the duodenal mucosa is dysfunctional. And this occurs early in the pathogenesis of metabolic disease. And we know that in patients with duodenal dysfunction, this will correlate with poor outcomes. And we know from bariatric science that the proliferation of the duodenal mucosa, which is caused by excessive exposure to high sugar foods, and is the root cause of insulin resistance. And we've seen this in patients with not just type 2 diabetes, but also obese patients where there is duodenal mucosal dysfunction. And you can see this animal work, which was done a couple of years ago, very elegant work showing that in mice that were fed with a high sugar, high adipose diet, not only had a higher BMI, but they also had an increased surface area, but also weight of the small intestine, as evidenced here by the increase in villus length and a decreased crypt density. And you saw this increase in endocrine cells due to the increase in goblet cells. And so we see this when we look at plasma citrulline, which we all know is a biomarker for nutritional and intestinal failure. When we look at these, that in folks with high A1Cs and by definition poorer glycemic control, the blood citrulline levels are indeed higher, so suggesting a level of intestinal failure. So we don't need to go too far to look at the gold standard for not just obesity, but for metabolic disease, where we know that in patients who have a Roux-en-Y bypass, where we bypass the proximal foregut, they see an almost immediate improvement in their type 2 diabetes. And compared to medical therapy, compared to non-intervention, gastric bypass is by far the most effective metabolic intervention, superior to dietary intervention alone. And we know that this glycemic benefit is independent of weight loss. And I think that's a very important analogy to use when we go forward in the next part of this lecture, describing the endoscopic roles for insulin resistance and metabolic syndromes is this is not a weight loss intervention. We're trying to look at a metabolic effect. So this is summarized here that if we look at a rodent model where we carry out a Roux-en-Y gastric bypass, and then we put in a gastrostomy tube into the remnant stomach, that actually, once we have seen that initial improved glucose homeostasis, when we then re-expose the remnant stomach to nutrients, it reverses that glycemic benefit almost instantaneously, lending weight to the hypothesis that I'm spending a little bit of time setting the scene. So when we look at metabolic surgery, and by definition, then also metabolic endoscopy, there's two hypotheses. And the one that we're most interested in is the foregut hypothesis, that if we can exclude or manipulate the proximal small bowel, it will reduce the secretion of these anti-incretin signals and lead to a metabolic benefit. So the mechanisms that I've alluded to after bariatric surgery that lead to type 2 diabetes remission are multifactorial, but we know that this proximal foregut theory carries a lot of weight. And so a proof of concept to duodenal manipulation and duodenal ablation was this study that was carried out several years ago now, before we did any of the human work. And it was in rats, where we used duodenal abrasion with an abrasive brush. And post procedure, this led to a reduction in blood glucose versus sham animals. And you can see that it also led to a completely normal regeneration of duodenal mucosa after the initial injury. And this was demonstrated here also using PDT, showing that in patients who, in rats again, that were fed high-fat diets and they went intraduodenal PDT versus sham procedure, you can see the villus length was significant increase. So lending weight to this hypothesis. And this really set the scene for duodenal mucosal resurfacing, which is, of all the duodenal techniques, probably the one that has the most data and the most publicity. And it essentially replicates these effects of a gastric bypass by a hydrothermal ablation of the proximal duodenum. So it is a balloon-based intervention that involves both direct endoscopic vision, but also fluoroscopy. It involves a catheter that is a bespoke catheter that is passed over a guide wire into the proximal duodenum, as you can see here. The 2-centimeter ablation balloon also has injection needles that carries out a submucosal injectate into the duodenal mucosa to create this barrier and this cushion to mitigate against, number one, perforation, but also number two, any medium to long-term sequelae such as stenoses. So you can see here, by circulating hot water for up to a minute in this balloon, you get this coagulum forming and this progressive duodenal ablation. And we progress the balloon under a combination of direct endoscopic vision and fluoroscopic guidance from just distal to the papilla, all the way down to the ligament of Treitz, and also a little bit further if we can. And by the end, you see this uniform ablation of the duodenal wall. So what do the data show? So there have been many prospective first-in-human single-arm trials, but I think probably the landmark trial is this sham control study, which was carried out across Europe and across South America. And it looked at patients with poorly controlled type 2 diabetes in whom we either did the Revita, the duodenal resurfacing procedure that I just demonstrated to you, or they had a sham procedure and then crossed over. And if I just concentrate on the European data, because there was some, once we looked at the Brazilian data and we looked at the European data in isolation, the European data were more significant. You can see that compared to the sham procedure, significant reduction at 24 weeks of A1C, but also other parameters of metabolic health, so liver MRI and fatty liver scores were improved as well. And we've seen that in subsequently published data, there are now 2-year outcomes showing benefit. So, ladies and gentlemen, whilst duodenal mucosal resurfacing is still in its infancy, what we have seen, as we saw at this year's DDW, there are now emerging technologies that are manipulating the duodenal mucosa and mimicking the benefits that we've seen with DMR. The one that probably has the most traction to date is electroporation with the Endolumincal device. And again, this is an over-the-scope device that uses electrical field pulse electrical field activity. It's called the resect procedure. We in our group have been working on vapor and steam ablation, which has a unique benefit of being through the scope, but uses radio frequency induced vapor ablation and steam to treat the duodenal wall. And again, our group is currently in the final stages of completing our animal work on the use of cryoballoon, again, a through the scope device to treat the duodenum. So the Endolumincal device is extremely attractive in that it is a non-thermal ablation technology, so potentially carries some of the advantages of mitigating against scarring and stenoses that potentially would be a sequelae of the other heat-based therapies. These are the data that were published now over 12 months ago. The first in human trial showing that at 24 weeks, you can see with a double application of the energy, again, a significant improvement in A1Cs in patients with type 2 diabetes, similar to what I showed you with the Revita procedure. And we can't shy away from the fact that if we think that we're going to treat type 2 diabetes or metabolic disease in isolation, then we're going to be fighting a losing battle, because in this era of the GLP-1 medications and combined GIP and GLP, and now GIP, GLP, and glucagon medications, we have to look at multimodal treatment. And this is a very elegant study, although only in a few patients, looking at a combination of semaglutide and electroporation to show that in patients who were type 2 diabetic on insulin, we can pull them back and reduce insulin at 1 year, and you can see a significant reduction in A1C from 7.2 to 6.6. So there's more than one way to skin a cat, and we look at some of the competing technologies. So this is RFV, so this is steam therapy. So this is using the concept of radio frequency energy to convert vapor into steam. And this is a device that we've just finished our first in human study in South America, and the second study is about to start. And the data were presented at this year's meeting in DDW and have just been submitted for publication. And the benefit of this is this device goes through the working channel of a therapeutic endoscope, so it can be done on direct vision, and does not need fluoroscopy. Similar concept where you are ablating distal to the papilla and using the 2-centimeter treatment zone that is within these two baskets, the steam is released and causes an ablative insult to the duodenal lining. And the procedure is repeated by reducing the balloon, the baskets, progressing the catheter, so on and so forth. So in essence, you can treat either 5 sequential zones, or you can keep treating until you get to the ligamented triads. And if you look at our early data, these again were submitted and presented just a few weeks ago, showing really attractive outcomes of an A1C of 80% of the patients who had the treatment had an A1C reduction of greater than 0.5 in 6 months. And whilst we can't compare apples and pears, if we look at the 3 modalities, so steam, endogenics, and duodenal resurfacing, there's some early signals here of equivocal efficacy, certainly in the 6-month period, in terms of the percentage improvement in A1C. So really exciting times for duodenal ablation. So we have these 3 devices that are currently being trialed in humans, and each has distinct advantages and disadvantages. and in essence show very similar reductions in A1C, both at 6 months and hopefully at 12 months. Very quickly, our lab has been looking at the use of cryoballoons. This is animal work that was carried out a few months ago. And you can see that the cryoballoon that we use for Barrett's shows really uniform ablation of the duodenal mucosa, and the first in human protocol has recently been submitted. So in summary, ladies and gentlemen, metabolic surgery has set a footprint as an excellent treatment for type 2 diabetes with a multitude of different mechanisms that have been proposed. But in particular, the foregut theory is that if we can manipulate the intestinal mucosa of the proximal small bowel, that we can cause benefit. And we know from animal studies that there is dysfunction of the duodenal mucosa in hyperplasia. And as a result, therefore, targeted and safe duodenal ablation can be used to target this underlying mechanism. And the early evidence that I've demonstrated to you has shown a very good safety profile that is reproducible amongst different portfolios and platforms, and long-term data are still required. Again, I'd like to really thank everyone who organized this course, and thank you for the opportunity to speak to you. And I hope you enjoyed the rest of the Congress. Thank you very much.